Thank you so much, everyone. So today I'm here to talk about ocular cicatricial pemphigoid, and I'll just throw some highlights of it in a brief manner in the time available, and also through some brief cases try to highlight important points. So with OCP, I think the most and important thing is to make the diagnosis as early as possible, and once we have made the diagnosis, arresting progression of the disease becomes most important, because it's only in the earlier stages why if we rehabilitate them, they have the best outcomes, because once they reach the later stages, it becomes very difficult to rehabilitate these patients. Often during the course of the management, you will have exacerbations and you need to be equipped to address the complications. So this is how I'll briefly take the overview. So ocular cicatricial pemphigoid is, or nowadays more than it's a subset of a systemic MMP, and it is classified by the linear deposits of these immunoglobulins IgG, IgA and complement C3 in the epithelial basement membrane. It's important to know at least the most common DDs like post SJS, post adenoviral. Some of them can have, after severe this thing, can have subconjunctival scarring, symblepharon. Pseudopemphigoid, drug induced, most commonly after anti-glaucoma medication. The reason that we have to differentiate them, because the line of management becomes very, very different. So that is one reason why we need to know some of the salient DD at least. OCP diagnosis is predominantly clinical, although HPE also is supportive in the diagnosis. And the main challenge with OCP is very often the chronic red eye is gets treated differently as conjunctivitis, allergy, and is often missed, and the diagnosis is delayed. In fact, studies by Foster's group have shown that more than 86% of patients have 50% or more of pharyngeal shortening at the time of diagnosis, and the mean duration of the initial onset of symptoms to diagnosis is 2.8 years. So this very, very long lead time is essentially because of the relatively lower knowledge of OCP and diagnosis of OCP in the general ophthalmologist. So OCP is being a clinical diagnosis that you are looking at the typical features in the tarsal and pharyngeal conjunctiva. Look for early symblepharon, and any chronically inflamed surface in an older patient, definitely suspect OCP. Stage 1 is the subconjunctival fibrosis and bands which you see, which is very, very important to identify at this stage. Even if it gets missed, at least at the early pharyngeal shortening at stage 2, if we identify the patients in this stage 1 or 2 and immediately start and keep them on treatment and regular monitoring, we are able to achieve reasonable outcomes. But once it starts progressing into symblefera and progressive symblefera and ankyloblepharon and surface failures, it becomes very difficult to manage these patients. Documenting with serial slit lamp photographs is one of the best indicators of disease progression or activity. While biopsies are useful, some of the ways where, because the range of positivity depending on the study which you're seeing varies from 22 to 75%. And some of the ways we can increase the yield of positivity is by including the conjunctiva just adjacent to the inflamed conjunctiva. You could add immunoperoxidase techniques, which has been proven to show increase the yield. And there are some papers which even say that some of the biopsy negative OCPs will probably have an even more aggressive course. So it's really, once you have diagnosed OCP clinically and you're seeing you have to initiate treatment immediately. While dapsone is there in many papers, I think more often than not, methotrexate, azathioprine in mild disease is started. Moderate disease, mycophenolate mofetil is very good. The side effects are very less, can be tolerated and can be used over a long period. And these are treatments easily which we as ophthalmologists can initiate and monitor these patients, and you don't really have to rely on a rheumatologist or an internist. Later stages, once it goes to a very severe disease where a requirement of cyclophosphamide, rituximab, IVIG is required, you would have to involve an immunologist or internist, but at the same time, you will have to convince them, because very often a rheumatologist, by just looking at a red eye, will not be willing to start cyclophosphamide for the patient. So highlighting the importance of starting it for these patients is very, very important. I think going into the individual side effects and this thing of each of these drugs would be beyond the scope of this time. But documenting progression, like I said, is best indicator. Once you have achieved remission, continue the treatment for at least a period of 1 year, and once you've achieved remission, we can consider visual rehab. Now, just achieving remission alone can improve clarity, and some of these patients, if they have adequate phonesis, can be fitted with a scleral contact lens and they do quite well. Some of these patients, once again you achieve remission, in that window period when you have a relatively clear cornea, do a early cataract surgery after 12 weeks. Because again, once a subsequent remission comes, a cataract surgery can become quite difficult. Your techniques may have to change. You might not be able to put in a speculum. Using traction sutures, all other techniques would be required. And you could also do a phonics reconstruction to fit them with scleral contact lenses, either with mucous membrane grafts or conjunctival autografts, once you have achieved complete remission and the disease is under control. Alloslate in OCP to be used very, very carefully in very select cases where the eyes are relatively wet. Anyway, these patients are on immunosuppression, and the immunosuppression will be continued even after alloslate. Alloslate is not going to be a final treatment for these cases. It's just buying us a little bit more time before an eventual K-Pro for these patients. Just an example of a wet eye where you have a significant pannus which has grown and you can do it. You may have acute exacerbations during the course of the disease leading to corneal perforations, and you have to either treat them with tissue adhesive cyanoacrylate glue or Tenon patch grafts. And once you step up the immunosuppression and treat the acute exacerbations, you can still go back to scleral contact lenses. Again, a bilateral acute exacerbation in a patient which had to be managed very aggressively with IV cyclophosphamide and IV methylprednisolone, use tarsorafis, other techniques to ensure that you can save the eye and achieve remission with these drugs. Then you can later, in these kind of surfaces where it's a very dry surface, there's significant keratin and complete ocular surface failure, you could do either a type 2 K-Pro, OOKP, modified LVP K-Pros as staged procedures. Of course, these patients all require long-term follow-up. These are challenging cases to handle. Very often you will, during the course of post-op management, have challenges like focal mucosal melts. You have to combine them with MMG immunomodulation tarsorafis. They develop glaucoma. You could do a valve as a primary procedure, or secondarily after lifting the mucosal flap and do a glaucoma drainage device. So these are really long-term managements, and various options are necessary, multitude of options to treat these patients. It's a wide spectrum, the OCP, from a mild to a very advanced disease. It's really early diagnosis and prompt initiation of therapy, and combination of these surface procedures with immunosuppression can give promising results. Thank you so much for your kind attention.
Very good talk, very well covered. Is there any role for a biopsy in these cases, because it's seen easily? You can clinically itself you can evaluate in most cases.
I think there's a definite role for biopsy. I was not trying to say biopsy is not important. I meant there is, depending on the quality of the lab that you have available, the positivity rates can vary significantly. Multiple studies have shown a wide variety in the positivity rates, but even if you get a biopsy negative, but clinically all the features of OCP are there, we would still initiate aggressive therapy and not wait for the biopsy to be positive before we initiate systemic immunomodulation.
In fact, Shreyas mentioned, I think also that biopsy negative patients have a worse prognosis and a worse clinical features.
Thank you.
Some cases what we have clinically suspected OCP, biopsy came as lichen planus. It will exactly mimic the same, but of course therapy also will be almost same,
Similar.
but they are lichen planus.
Yes, ma'am.